Dear ladies and gentlemen, welcome to today's seminar. Speaker on today's seminar will be me, Michael Senior, and Maria Schweidler. The rest of our speakers are in European Congress in Vienna right now. Okay, I will start with the first case. I start with amazing new thing in human pathology. It is a lung tumor with such mucinous tumor for which the typical occurrence are these lakes or these big structures that reminds similar lakes that can be sometimes seen in myxoid liposarcoma. We had this case for many years, for 8 years, and 8 years ago, the late Andra Hess described this lesion as probably myxoid liposarcoma, which at his time was the best diagnosis, I guess. But this tumor now was described as a tumor having recurrent mutation PDGFB, which is a mutation that could allow patients to be treated by imatinib if the tumor would be too large or too recurring. Yeah. But the 6 cases they published about this tumor behaved in a benign way. They call the tumor microcystic fibromyxoma of the lungs. I have a paper for you. This tumor, yeah, which was published very recently, and you can see the same lakes like I showed you. The tumor they showed in this paper looks like the tumor I showed you. The tumor is TTFR negative in the lungs. It is CD, I guess CD4 positive. I'm showing one newcomer. I'm showing the tumor of the lungs. I maybe gave you the slide. So, without knowledge of this tumor, which looks quite malignantly, but which behaves in a benign way, is a small sign in human pathology. Now I have another amazing case of salivary gland or nasal cavity. It was I guess, female, and it was a consultation, I guess, from Italy. It was a female patient, and you can see, first thing, it is these structures which qualify for REAH, respiratory and rheumatoid hamartoma. But it's not what I know. But then there is this neoplasm which has some features of microcystic carcinoma of salivary gland, but we didn't find a typical fusion for this tumor. The fusion, I guess, SS18 fusion partner. The second partner I forgot. Yeah. But why am I showing you that? When you look here, you will find so-called atypical adrenomatous structures that arise from cerebrospinal hamartoma. These are these atypical structures, as you see here or here, which slowly transfer into the tumor. Yeah, here you can see them. And these atypical adrenomatous structures, as you can first of all see here or here, are the preneoplastic lesions of many tumors. We described several of them, but this lesion is this tumor, which is having a mutation that is called REQL4. I never heard about it, and it was never found in any human pathology. Yeah, I see adenomatous structure. Yeah. It will be a new type of tumor in human pathology arising on this preneoplastic lesion. We just prepared this tumor for publication. Here I have a staining for lysozyme, which is a relatively specific staining for typical adenomatous structures and cerebrospinal hamartomas. I'm not sure whether I will be able to find it easily the place. No, I can't. I would be looking for it for a long time. Yeah. Okay, to sum it up, it is cerebrospinal hamartoma with REAC coming to atypical adenomatous structures, and these give rise to a tumor that looks like microcystic carcinoma, but it is not, because the mutation is very unusual, and I didn't find any other neoplastic lesions in human pathology having this mutation. Yeah. Next lesion is the skin lesion. You can see here huge proliferation of sebaceous glands around. Even here, it is described grapes of bananas, which was sometimes considered to be specific for so-called what is the name of the tumor? Syndromatic tumor.
No.
Just I forgot the name of the syndrome. Syndromatic lesion. But okay, it is syndromatic lesions that give rise to this sebaceous proliferation. But we published with our Kveta, and we recognize that it's only reactive hyperplasia secondary to spindle cell lipoma or fat-free lipomatous tissue. You see very nicely here the spindle cell lipoma around. Yeah. The name of the lesion is trichodiscoma. Yeah. Trichodiscoma is a tumor that can arise either solitarily or within a syndrome. Yeah? But we found that these non-syndromatic lesions are always caused by mesenchymal proliferation, like spindle cell lipoma, like in this case you can see it here. And as usually, this spindle cell lipoma is having retinoblastoma protein deficiency. Here you can see staining of retinoblastoma protein. You see that the reactive lesion of sebaceous gland and follicular lesions are negative, but stromal lesions are positive and stromal lesions are negative. Yeah, so that this trichodiscoma with hyperplasia of sebaceous and follicular components, and stromal lesion is spindle cell lipoma, which is LB1 negative, and all of that is reactive. I found very interesting lesions very recently, which is not described so far. It is this one. Again, skin lesion. And you can see very nicely in one of these 4 lesions, hyperplasia here, hyperplasia sebaceous glands, but this hyperplasia is deeply in the tumor. Yeah, you see even suggestions of banana growth here, but superficial sebaceous glands are negative. That means I think it's identical thing. It is, you see around it spindle cell lipoma with hyperplasia sebaceous glands, but which is not superficial, so that you cannot call it as the tumor. And the stromal lesion, you can see here, is spindle cell lipoma, and again we did RB1, which was negative. Okay. So we think that this hyperplasia of sebaceous glands can be not only superficial, it can be deeply localized in skin, and trichodiscoma, most of them are no entity at all. Most of these, or all of these trichodiscomas are just spindle cell lipomas or fat-free lipomas, which is the one type of lipomas, causing these sebaceous glands to proliferate and look like, very widely look like bananas, grapes, and I don't have here the paper of Kyoto because I didn't find it at the last moment. Here I have again a new tumor of soft tissues. It is you see subcutaneous tumors, and it's quite cellular. Yeah? You might even think that it's type of hemangioendothelioma, which is a low-grade angiosarcoma. Yeah? There is a mild atypia in it, some foam cell proliferation. You may have a clue that it's the tumor when you stain it with antibody to ALK, which is here, ALK antibody. And when you do angiosequencing, you find a typical recurrent fusion. And it is this fusion, and it is actually the case that my son submitted to this case report as a case report to this group, and my son is co-author of this paper that was published just 2 months ago in American Journal of Surgical Pathology. It's benign tumor. It's not hemangioendothelioma. It's something like epithelial with hemangioma. It's perfectly benign, and you should not call it angiosarcoma or hemangioendothelioma. The recurrent translocation is called TMP3, 4 or 4 ALK, yeah? Here, soft tissue lesions of 6 centimeters, that was at gluteal region. Maybe even smaller. And it is so nicely lobularly arranged. You can see the nodular arrangement. And the centers of these nodules are necrotic. These lesions were recently described by Raoul Perret. He described 7 lesions of this. He found that all these lesions of his were YAP1 mammal2 translocated. And microscopically, you see the lesion is typical MIFS, typical sarcoma, mixed inflammatory fibrostic sarcoma with these typical soccer ball-like cells with emperipolysis. And as to mixed inflammatory fibrostic sarcoma, you should know that we have now in our files close to 100 cases, and genetically these lesions can be very heterogeneous. This lesion can have many types of recurrent mutations or translocations, and YAP1 mammal2 is one of them. But the question is whether it is really specific translocation to these nodular necrotic lesions, because Dr. Dharmavan just very recently described a small series of YAP1 mammal2 translocated mixed inflammatory fibrostic sarcomas that didn't have this nodular change. Okay, let's for the future. When you see this nodular arrangement with microscopic diagnosis of mixed inflammatory fibrostic sarcoma, let's try to do genetics and to find this typical recurrent translocation. Now I have lesions of liver, quite large lesion of liver, and you can see this dominant thing, the basophilic tumor. There is infiltrative borders, and I think it very clearly qualifies for infiltration of a carcinoma, so the hepatocellular carcinoma. But it's not all. You see around here something else. It looks like fibrosis or scar, but when you look at it more carefully, you will see that this scar-like tissue have cells that sometimes produce these, I don't know if it should come in. That have these monocellular luminization with erythrocyte inside of it. You can see one, you can see one in the middle. And the surrounding of the tumor is epithelioid hemangioendothelioma, which was CAMTA1 translocated, and which is typical for these tumors. So the diagnosis in this case is well-differentiated hepatocellular carcinoma surrounded by low-grade sarcoma of epithelioid hemangioendothelioma. Epithelioid hemangioendothelioma is typical mesenchymal tumor of liver, and the prognosis depends on whether it's got other foci in lungs or other visceral lesions around. If it is surrounded or limited only to liver, it may behave relatively prognostically better. If it is in all these tumors, all these organs I mentioned, especially the lungs, the prognosis is very malignant. Now I have a patient, older patient with subcutaneous lesion, making these angiomatoid structures which do not make typicality of the tumor, and hemosiderin deposition, so that it's not melanin, it's hemosiderin. And the tumor is very important to know and diagnose. You see, it's very dysplastic. You do not see many mitotic figures, yeah, when you look at them, but you see huge proliferation, huge atypicality within the tumor. Typically, the tumor is CD34 positive, and 3/4 of the tumor, when you do angiosequencing, have fusion of parameter 1 gene. The fusion partners can be various. EWS-R1 is the most frequent one, but others are possible as well. So it is called so-called CD34 positive neoplasm of the superficial soft tissues. They are now in WHO classification, and they mostly behave in benign ways. They have described very rare cases which metastasize to local region place, but survival in these patients is excellent, so that it looks like wild sarcoma, but still you should make the right diagnosis because the tumor relatively is quite benign lesion. Are you scared? You know, 46-year-old woman with tumor of thyroid. And very important thing is that this lesion, which is quite clearly low-grade malignant neoplasm, is thyroglobally negative. It's the first thing that should make you point to the diagnosis. Yeah, what it could be? If you stain it with STAT5 or S100 protein, it's always positive. So that is one of the rare, but we have several cases in our files. It is one of the rarest secretory carcinoma of thyroid, or as we described it with Anna Skalova 15 years ago, as mammary type secretory carcinoma, which sometimes, like in this case, can appear primarily in thyroid and not in salivary gland. Yeah. Important to know because the lesion usually behave in a benign way. I'm not sure that it is radiosensitive as this papillary carcinoma, so that surgery usually is the winning method to fight this tumor. Okay, the diagnosis: primary thyroid, example of mammary analog secretory carcinoma of thyroid, now called only secretory carcinoma, which is identical tumor to other locations like especially liver, and we described several cases in skin as well. And we have even one case that occurred within mammary-like glands of vulva. Yeah, so they can appear even in vulva arising from mammary type glands in vulva. Now I have a very nice case. It's a female, a young female, I don't know precisely the age, and the female had tumor of ovary. You see the ovary here nicely. And the tumor was on surface of ovary, where at the place where it's attached to fallopian tube, and it continued to broad ligament. It's benign tumor. I see it for the second time in my life in fallopian tube and broad ligament. And it's called papillary cystadenoma, typical of Hippel-Lindau disease. Yeah? Hippel-Lindau disease is are patients that have germline mutations of VHL gene. This patient had VHL gene mutation, but what was amazing, this patient, usually these patients are having clear cell carcinoma of the kidney. This patient had tumor of the kidney, but it was not clear cell carcinoma, but it was mixed epithelial stromal tumor of the kidney, which is a tumor we discovered here 27 years ago. And I think it's the only case that was associated with this mixed epithelial stromal tumor of the kidney. Yeah? Usually you see this proliferation in the testes.
Broad ligament.
In broad ligament, yeah.
And the lymphatic sac tumor or Hefner tumor is.
They have several other.
It shows essentially the same morphology.
Yeah. It can occur with endolymphatic cell tumor, which is called some Hefner tumor. Hefner tumor, and many others, paragangliomas and others. Yeah. So that it's very important to know when you have this tumor in ovary, or especially in testes, you can be pretty sure that the patient is having mutation, germline mutation of VHL, and the patient is having Hippel-Lindau disease, and most probably at the time of diagnosis he will have clear cell carcinoma of the kidney. Yeah, and here is older woman with large neoplasm of ovary. The ovarian tumor qualifies for borderline mucinous tumor of ovary. This would not be as unusual if the lesion would not have one more thing, but I must find it. Yeah, it's here. It has such nodulus of neoplastic cells, which are rhabdoid. I think it's, I would call it, because they are cytokeratin positive, they are cytokeratin, it's a nodule of carcinoma. And you see clearly it's a rhabdoid morphology, and it had this lesion, this nodule, was even having deficiency of SMARCB4 by immunohistochemistry. Yeah, and it's well known that these nodules, in 40% of the cases, have deficiency of one of these markers, SMARCB1, SMARCB2, SMARCB4. Yeah? And when you see this lesion with SMARCB4 deficiency, do you have some suggestion of other tumors?
Yeah. Small cell carcinoma,
yes.
hypocalcemic type, large cell variant.
Yeah, the small cell carcinoma of ovary has usually small cell featured, but not rarely it has large cell variant, which looks identical to this, and quite often these tumors are having mucinous glands. Not often, rarely. But these are very well known to this. If this component would overgrow the kidney, ovary, it would make the tumor. Yeah? So that it is nodulus of epithelioid-looking carcinoma with SMARCB4 deficiency, and some people might say it's beginning incipient large cell variant of hypercalcemic carcinoma of ovary. This very nice paper, it was described recently. Co-author is nobody else than Abasagaime. And you see that these markers like SMARCB1, SMARCB2, SMARCB4, and Claudin4, which belong to the same things, are quite often having deficiency in these proteins. Yeah, it's quite important because when it behaves in a malignant way, there is targeted therapy which is shortly lived but still better than nothing. Yeah. Okay, my last case, again ovarian case, older woman. The case was beta-catenin nuclearly positive, cytokeratin positive, CD10 positive. And the diagnosis, and you might notice one thing, that some areas are not that different from solid cystic tumor of pancreas. Molecular genetically, it was beta-catenin mutated or CTNNB1 mutated. It was described as a separate tumor, but we think, or I think, that these tumors, together with secondary stromal tumors of ovary and testes, belong to the same group of tumors, and we are preparing methylation profiling to show that it's the same lesion. In testes, when this appears, usually it's called by a group of Dr. Albright and Acosta, they would call it a certolysal NOS, which I disagree, and we already exchanged several letters to editor, but I will prepare a paper that will show all these tumors like macrocystic stromal tumor or solid cystic tumor like pancreas and strange hard structures within one lesion, of beta-catenin mutated tumor, and it appeared in testes. Okay, it's for today all, and
Now again, I've got a mixture of GI, pancreas, and CNS, and maybe some soft tissue cases. My first case is biopsy from the pancreas and in consultation. This is the original H&E staining, so it's not that good, that nice as ours, but still it's quite nice. So this is a let's say older male patient with a pancreatic mass, and this is the biopsy from the pancreas. And yes, I believe that everybody would agree that it's clearly high-grade malignant lesion, showing this cohesive single-cell growth, and the cells are having this almost rhabdoid-like appearance. Okay, so in this scenario, so this is not very typical aspect of pancreatic carcinoma, but it still could be carcinoma. So the lesion is positive for cytokeratins, and importantly, if you see a case like this, showing this cohesive growth pattern with rhabdoid-like cells, you should perform your SNF complex proteins staining, including SMARCB1, SMARCA4, and SMARCA2 antibodies. And in fact, this tumor, I believe, was SMARCA2 protein deficient. So this can be called, this is the immunohistochemistry. You can see some staining in internal controls, some stromal cells, and tumor cells are SMARCA2 deficient. So this can be called anaplastic carcinoma of pancreas with SMARCA2 deficiency. Okay. So why is this important? It's quite important because the studies are still ongoing, but probably these tumors may have some benefits from immune checkpoint inhibition. Okay, so otherwise this is very, very aggressive tumor type. My second case is tumor of the brain, again sent in consultation, and the patient is let's say middle-aged female, and location of the tumor is supratentorial frontal lobe, and it shows this quite interesting morphology. Tumor cells are quite monotonous looking, are cytologically relatively blunt, roundish nuclei, not many mitotic figures, maybe none. No necrosis was present, no microvascular proliferation. There are some microcystic parts filled with this myxoid substance. So it looks like something low-grade neuroepithelial, let's say. And they performed quite a lot of immunohistochemistry, some basic molecular genetics was applied, and the tumor couldn't be classified. It's not IDH mutant, it's not glioblastoma IDH wild type, so we have used methylation profiling, and to my surprise, the results came back as a CNS B-core altered tumor, and more specifically CNS tumor with EP300 B-core fusion. So for some time we have already in WHO Blue Book a category of mostly pediatric tumors with B-core internal tandem duplication, and there is a emerging new entity of tumors showing not ITD but B-core gene fusion instead, or sometimes even mutations in the B-core genes. What is interesting in this case is the morphology of the tumor, because as I will show you in the paper, let's say the first one. Okay, when we look how these tumors look like, most of them show like quite heterogeneous morphology within the same tumor specimen, and we'll show these. Most of them have this ependymoma-like morphology, sometimes oligodendroglioma-like morphology, and even small cell embryonal tumor type morphology. Most of these tumors show clearly high-grade morphology with plenty of mitotic figures, necrosis, while microvascular proliferation is almost never present. Okay, so this morphology quite in our case quite differs from what was described in the literature. So this case probably expands the morphological spectrum of B-core rearranged CNS tumors, which are not included in the most recent WHO classification, but it's emerging entity. And these tumors, in contrast to these tumors with ITD, B-core, ITD, occur more frequently in adult population. Otherwise, the morphology is quite similar. This embryonal ependymoma and oligodendroglioma-like morphology. You can see these microcystic structures, but otherwise the morphology is quite different from our case. So there will be probably new group of tumors, mostly of adult population with B-core fusions included in the next WHO classification. So I believe the case is worth publishing, so we probably will write case report. Okay, my next case is again middle-aged female with meningeal tumor. Probably, maybe I will show you frozen section first. It's here. So frozen section in brain tumors is not the best method. I like more cytology. If you see this aspect of this frozen tissue, you can tell. Yeah, it can be meningioma, but some other entities may be included, and the cytology performed during the frozen section will show you these big clumps of essentially not smearing, so it's something mesenchymal-like with these dark staining cells. So could it be meningioma? Maybe yes, maybe not, maybe something other mesenchymal. And I will show you the definitive sections of the tumor. And if I go to this very low magnification, you almost immediately have your most important differential diagnosis. So the tumor is composed of this very monotonous proliferation of these ovoid cells, and what is very typical characteristic are these weirdly shaped, sometimes staghorn shaped, here vessels, and the tumor will be positive for CD34 and also will be positive for STAT6. And you don't need any other staining because it's solitary fibrous tumor, or previously called hemangiopericytoma in the CNS. Okay, so solitary fibrous tumor of the meninges. All right. Okay, my next case, it's older patient with a gastric biopsy. So there was a lesion in the gastric body, and you can see here this neoplastic proliferation. And maybe just by looking on H&E, you can call it adenocarcinoma, but you have to be really suspicious if you see these solid growing, essentially undifferentiated malignancy, not to call it wrongly adenocarcinoma. And there was a quite important piece of information on the requisition form. The patient was known to having another lesion in his lungs. So we stained for several markers, including squamous. This is P40 staining, and cytokeratin 5/6 were also positive. So this is metastatic, poorly differentiated squamous cell carcinoma of the stomach. Okay, so the message from the case is, if you see undifferentiated or very poorly differentiated neoplasm, you should be highly suspicious and do some staining, not to call it adenocarcinoma, because obviously the management is completely different. So my next case is another quite old male patient with pancreatic mass. So this is a needle aspiration biopsy from the pancreatic tumor, and you can see maybe some residues of pancreatic tissue here, and otherwise you can see this, let's say, solid with little bit, maybe hint of acinar formations, clearly malignant, and, or let's say malignant. The cytology is not very bad, yeah? So what's in the differential diagnosis when you see a tumor like this? Neuroendocrine tumor will be one of the options. The patient is male, but otherwise, if it was female, solid pseudopapillary neoplasm of the pancreas is the second possibility. And the third possibility, when you see this solid and, let's say, a little bit acinar formations, is acinar cell carcinoma. So neuroendocrine markers were completely negative, and this is staining for trypsin. Okay, so I use only trypsin staining for acinar carcinoma of the pancreas. So these are normal structures of the pancreas here as internal control, and the tumor cells are here positive for trypsin. So this is not very common tumor type, and we should always think about that when dealing with solid, so-called solid tumor of pancreas. Okay. Okay, my next case is another pancreatic biopsy. As you can see here, it's again, in this case it's, let's say, younger adult patient. You can see still normal pancreas here, normal pancreas here, almost nothing. Okay, and then there are only these very, very small pieces of tissue showing something else. So clearly high-grade malignant tumor composed of these very small cells with apoptotic bodies. There are some mitotic figures here. So if I see something like this in the pancreas, I will mentally go through all the possibilities if it could be some primary tumor of the pancreas, and the answer is it doesn't look like primary tumor of the pancreas, or it's something very, very rare primary in the pancreas. Okay, so most important differential diagnosis in this case would be small cell carcinoma. And in fact, this is INSM1 staining, which is considered to be one of the best neuroendocrine markers there. And the lesion was also positive for synaptophysin staining and MIB1 index, so proliferative activity was close to 100% cells, so my final diagnosis was small cell carcinoma, probably metastatic, so clinicians should check whether there is something else in the body. The most probable location is, of course, the lungs, but small cell carcinoma from other locations show essentially the same morphology, same immunophenotype, so they should investigate the patient, the whole body. Okay. My next case is middle-aged male. It's a gastric biopsy. And don't look for the tumor, but because there is none. And there is almost nothing in the lamina propria, so there is not even gastritis present in this specimen coming from, let's say, antrum, or the transition from antrum to the body. But there is one interesting thing present there, and it's here. You can see that some of these pylori glands, this very high magnification, show this brownish pigment within the cells. Okay, so the pigment is, or the particles are not present in the, here, it's maybe better. Okay, so there is discoloration of the cytoplasm of these glands. I have performed special stains for iron, and it nicely highlights how much of iron is present within the epithelium of the cells. So this is quite an interesting finding, because we recognize so-called iron pill gastritis, which is caused by supplements containing iron. But in these cases, the iron particles are present within lamina propria. Sometimes there is some reaction. They may be pictured of so-called reactive gastropathy or chemical gastropathy. But in this case, we have epithelial cells stained. Okay, so my differential diagnosis is, I've suggested to rule out some iron overload disease in this patient, because sometimes in these disorders, the typical example is hemochromatosis. Epithelial cells are preferentially having these iron deposits within the epithelium. So the liver may be affected, and when heavy iron overload is present, also epithelial cells in other organs may have iron deposits. So in this case, they should exclude iron overload disease, including hemochromatosis and some other mostly inherited disorders. Still, there's possibility that this is a secondary iron overload caused by ingestion of supplements, but the probability is lower compared to this other iron overload diseases. Okay, my next case is a skin biopsy. It's a very old female excision from the excision from the face, I believe, from the face, region. You can see clearly there is something here, tuberose proliferation. But let's start from the epidermis. You can see two things in the epidermis. I can see some pagetoid spread of neoplastic cells, as well as dysplasia in the cells. So this is essentially squamous cell carcinoma in situ. And within the squamous cell carcinoma in situ, there is a second component, it's pagetoid spread of this neoplastic proliferation, which is present in the dermis. And again, the tumor shows small cell morphology. We are on the skin. So this is staining for synaptophysin. So it's neuroendocrine tumor. And again, if you look at the epidermis, you can see this pagetoid spread of these tumorous cells. But some ugly looking cells, like here, if you look here in the middle, yeah, these are clearly these plastic cells not stained by synaptophysin. So this is really squamous cell carcinoma in situ, and underneath it's Merkel cell carcinoma. Okay, so positive for neuroendocrine markers with this very typical cytokeratin 20 staining. So it's more diffuse in this pagetoid component, but it's less in this dermal component. It's only dot-like positivity. It's very faint and almost hard to find. Maybe here it will be better. So we can see this fine dot-like staining of CK20, which is very typical characteristic of Merkel cell carcinoma. In this case, it was negative for Merkel cell polyomavirus, which is important to do because the prognosis of these virus-free tumors is worse compared to virus-associated tumors. Okay. Another case is very easy. It's a young male adult patient. This is excision from the leg, I believe. Yeah, from the leg. And you can see this very nice tumorous lesion composed of these mature adipocytes. And the second component is this chondroid-looking stroma with cells sitting in the lacunae. And this is one of the least frequent variants of lipoma called chondroid lipoma. Okay, it was done with correct diagnosis just to confirm that it's that. Okay, so I saw that lesion really very few times only. So chondroid lipoma. And probably my last case, because Michael was too long, is biopsy. It's tonsillar biopsy, older male. So we can see this not nice looking crushed pieces of tissue and normal looking squamous epithelium, but in addition we have this basaloid looking, quite ugly looking proliferation. Here, yeah. So in these cases, we should perform, always should perform, yeah, maybe here it's better. So it essentially looks like high-grade dysplastic in situ squamous epithelium, but the lesion is nicely P16 protein positive, and when the lesion shows this basaloid non-keratinizing morphology combined with P16 staining, you can call it HPV-associated oropharyngeal squamous cell carcinoma. Importantly, although the lesion is looking high-grade, poorly differentiated, you don't grade the lesions associated with HPV because the prognosis of the tumor is very good. And even in the immunohistochemistry, if you scroll around, the epithelium is on the surface. Okay, so it looks like inside the lesion, but there is nothing like HPV associated in situ carcinoma. You should always call it squamous cell carcinoma HPV associated with no added grade. And that's it for today, and I've got quite a big bunch of interesting cases for the next week.